Hello and welcome to this webinar. My name is Alex. I'm the senior vet at the Vet Hospital in Galston and I'm now nearing completion of the RCVS's Certificate of Advanced Veterinary Practice in General Small Animal Surgery. Today we're going to talk about the decision making and management of pelvic fractures. So what are we going to talk about? We'll talk about the decision-making involved, imaging, some specific presentations, so sacroiliac fracture luxation, fractures of the body of the ilium. We'll also touch a little bit on hip luxations and open reduction, when conservative treatment might be appropriate, when we might want to refer to a specialist, and also the post-operative care involved. I've related much of this to cats, as that's the species that we tend to see pelvic fractures most commonly in at our practice. However, many of these principles will also apply to dogs as well. So, just a little bit of background first of all. Reported in the literature, pelvic fractures tend to affect young, healthy patients following an episode of trauma in the majority of cases. A little aside to that is doing the greyhound track work that we do at the vet hospital. This is something that you can occasionally see in racing dogs, more as a stress fracture rather than following trauma. One of the more common places would be sort of through the acetabulum. A minimally displaced fracture through the acetabulum is something that we can sometimes see. But in the majority of cases, pelvic fractures present following quite high energy trauma, such as RTAs. The pelvis is inherently quite a rigid and strong structure, surrounded by a lot of musculature, so there has to have been sort of quite high energy trauma usually to fracture it, and because of that there quite often can be other more life-threatening conditions present at the same time. So things such as shock, be it due to hypovolemia or cardiovascular shock, arrhythmias, either due to hemorrhage or due to myocardial contusions, other intrathoracic injuries, so pneumothorax, hemothorax, diaphragmatic hernias or pulmonary contusions, and you can see the pneumothorax was present in this cat in this image here. Spinal trauma, CNS trauma or other nerve trauma, trauma to the urinary tract or other fractures with the more commonly hind limb but also the thoracic limb as well. So initial treatment and stabilization is what's going to take priority. So getting some pain relief on board, either methadone or buprenorphine. And again, as a lot of this will relate to cats, then buprenorphine can be quite a good choice in those cases. There was a study a few years ago that actually looked at buprenorphine versus morphine, and in cats, and they found that actually the pain relief was quite equivocal provided by the two, morphine obviously being the full mu agonist, as is methadone. There wasn't any studies that I'm aware of that sort of looked at methadone as opposed to buprenorphine and its pain relieving properties, but seeing as they're both full mu opioid agonists and buprenorphine just being a partial, it would kind of seem sensible that if morphine and buprenorphine were equivocal, then probably methadone is equivocal as well. And in cats you may get slightly less of the euphoria, and you would certainly get the longer duration, up to 12 hours in cats, associated with buprenorphine, so it may be beneficial in those cases. Fluid resuscitation, if the animal presents in shock, obviously is going to be important initially. Again, with cats, worth mentioning that if the animal is presenting hypothermic following trauma, RTA, etc., especially with cats, it's very important to get them warmed up again before you heavily fluid resuscitate them. Otherwise, that fluid is not going to remain within the intravascular space, and you risk pulmonary edema and major issues on that side. So the patient's body temperature is very important in cats. Supplying oxygen therapy as necessary, and then assessing sort of any other wounds, fractures, immobilizing those, and open wound management as necessary. Preferably just sort of flushing with saline and then providing a dressing and bandage. If the wounds are particularly dirty and contaminated, then actually in some cases just tap water and a sort of shower hose to remove some of that contamination. Not really ideal to be using iodine or chlorhexidine sort of directly in these wounds if we can. So then moving on to the diagnostics, ideally you want a minimum of a T-fast, so looking for that nice sliding bright B line just against the ribs and thoracic musculature. You don't really need to be taking thoracic radiographs initially, because if you're putting these animals in lateral recumbency, then you are potentially going to be causing more severe respiratory effort than is already present. So you can usually do this with T-fast in most cases initially, and then follow with thoracic radiographs once the animal is stable. Taking a PCV and total solids as a bare minimum. Ideally, pre-surgical and hematology would be better, because then you can evaluate azotemia, and we'll come into that a little bit later, the importance of that. Investigation of shock, so your physical exam findings, blood pressure, lactate, etc. An abdominal fast scan to look for free fluid, so again hemorrhage versus there being urine within the abdomen. If you do find free fluid on a fast, then ideally the next step is that you tap that abdominocentesis and obtain a sample. If it looks like blood, you can confirm that it definitely is blood by doing spinning down a PCV and comparing that to your peripheral PCV sample that you took, or equally, if it looks more like a transudate, or even if it looks like urine, if you want to confirm if it is urine, then you can put that sample through the normal biochemistry machine, run a creatinine on it, and then compare that creatinine level to the one that you got on your pre-surgical blood sample. And then as well, it's important to perform a neurological exam. You want to try and perform that as early as you can, because obviously once the pain relief that you provided gets on board, that's going to start having an impact on your neurological exam findings. But equally, sometimes it can be difficult in these patients that are particularly painful, so you have to kind of take that on an individual basis. So a little bit more about bladder rupture and investigation of the urinary tract. The bladder is the most common organ that is damaged with pelvic fractures, obviously due to where it is lying within the pelvic canal. Clinical signs, if you do have a urinary tract rupture, can include hematuria, dysuria, abdominal pain, distension, lack of a palpable bladder, free abdominal fluid that you've seen on ultrasound, and then that creatinine sample that we discussed, which tends to be higher than peripheral blood. Abdominal or perineal bruising, this does take sort of 24 to 48 hours to manifest itself, but it can be one of those sort of slightly later signs. And then, as we discussed about blood sampling, you can start to see a rising azotemia and creatinine, especially on sort of serial blood samples. So if you're suspicious that there might be a urinary tract rupture, then this is another way that you can monitor that. So if you have any doubt over the previous points that we've just discussed, that there may be a rupture, then really we need to investigate this first before we start looking at doing anything with the pelvic fractures. So we might do this by a double contrast retrograde urethrocystogram, which is what is in the image here, and this is obviously an image of a bladder that is no longer intact. Or if we are suspicious that the rupture may be a bit further cranial to this, so either renal or from the ureters in origin, then an excretory urogram might be the way to go to sort of confirm that. Renal or ureter damage is much less common than bladder or urethra, but it is still something that can be seen. So just a few points to be aware of is observing voluntary urination doesn't necessarily mean that you don't have a ruptured urinary tract. The animal still can urinate in these cases, and observation of hematuria either doesn't confirm and it doesn't rule out that you've got urinary tract rupture. The bladder can simply just become bruised through the trauma, and that can lead to hematuria. It doesn't necessarily mean there's a rupture. If you palpate or observe a bladder on ultrasound, again, it doesn't mean that there's not necessarily a small rupture within either the bladder, or it could be further down within the urethra, so that, again, that isn't a definite. These animals, because they are quite painful due to their pelvic fractures, they can have great difficulty in ambulating and posturing. So the fact that you're not observing voluntary urination doesn't necessarily mean that there is a major issue with the urinary tract. It may just well be the animal is sort of too painful to actually toilet normally. And you also have to be careful when differentiating between voluntary urination on the bed versus an overflow incontinence. So if there is nerve damage to that bladder and it's just simply becoming overly distended and then you're getting sort of leakage on the bed, it's important to be able to differentiate that from the animal actually not wanting to get up and get into the litter tray and just voluntarily urinating on its own bedding. So we'll do this by regularly palpating the bladder and sort of observing the bladder signs and the changes in the bladder size throughout the day. So there's quite a high correlation between urinary and fecal continence because the pudendal and pelvic nerves exit the spinal canal at pretty much the same area. So a cat that can urinate will almost certainly be able to defecate as well. So that's something that we don't need to worry about too much. If one's present, then so should the other. Other signs that you can use as well tends to be pain perception within the tail. So squeezing the tail, assessing for nociception within 5 centimeters of the tail base within 48 hours of the trauma is quite a good predictor of the bladder control returning if it isn't already present. And even saying that 60% of cats that don't have that sensation within 5 centimeters in 48 hours, 60% of them will still go on to recover as well. If you have intact perineal sensation and anal reflexes as you assess them, then again, that's a good prognostic indicator that bladder function is going to return within 30 days. However, if you end up with a cat that makes it beyond 30 days and it's still not urinating at that point, then the vast majority of cats are not going to remain incontinent. They're not going to regain any function past that point. Interestingly, you see sort of a tail pull injury here, which can commonly be associated with incontinence issues and nerve damage of the sacral nerve roots. The same study showed that tail function could take up to 150 days to return. So it can be quite important in these cases not necessarily to rush to tail amputation if it can be avoided, because it can actually take 4 months for tail function to return. Okay, so if we are looking at potentially having to wait up to 30 days for urinary continence to return, then clearly pelvic fractures can't wait that long. Because there is such good muscular blood supply around pelvic fractures, they are going to start to heal relatively quickly, and if we want to try and avoid malunion, then we really need to be tackling these fractures within 7 or sort of 10 days maximum. So what bladder management options have we got? We really want to avoid overdistension and overstretching of the tight junctions within the bladder, because that is going to lead to irreparable damage long term. So we need to try and manage that bladder, not only for comfort but also for long-term function. So we can potentially start off with daily manual expression. Depending on where the pelvic fractures are, then that potentially may be painful for the patient. It also, if the bladder is bruised, that's going to potentially be painful. And also, you can really rarely express the entire bladder, so there's always going to be some residual urine in there, and that potentially is going to predispose you to UTI. So potentially something that you could do initially over the first day or two if tolerated, but probably not something to use long term. So catheterization, if the cat is painful, that might be the next best thing. If you're going to use that, you've got to try and decide, are you going to intermittently catheterize the cat, or are you going to leave an indwelling catheter? They both got the pros and cons, as indwelling catheters may be more likely to cause a UTI, although having said that, there is a more recent study looking at blocked cats saying that actually leaving them catheterized for longer than 3 days doesn't actually increase the chances of them catching a UTI. Or you may be looking at sort of intermittently catheterizing them, but that is going to be more traumatic. So probably the best option, if you don't have return of continence past 5 days, is to actually do a tube cystotomy. So that's what the image on the right here is. Relatively simple to perform. You make a mini laparotomy, expose the bladder, place a purse string suture, put your tube in and inflate the Foley catheter, and then prior to closing your incisions, place a pexy to the abdominal wall so that you don't get any urine leakage. If you're going to do this, you need to wait at least 10 days before you then remove that cystotomy to allow a sort of strong pexy to form, so that when you remove the tube, you don't get leakage and your abdomen. So just a little bit of information on those less common but sort of potential other injuries to the urinary tract. So other things that we can see are renal lacerations. So this can potentially be treated by primarily suturing the renal capsule if possible, or if the damage is too severe, then ureteronephrectomy would be the other option. Urethral avulsion, I would be making it very clear that if you're dealing with urethral avulsion in any way, shape or form, the animal is going to have to be referred, because this is a very, very major, delicate surgery, often requiring specialist equipment, specialist training, operating microscopes, etc., to be able to do so. But there are potential ways in which this can be managed. So in some cases, the ureters can be reimplanted, either at the kidney or the bladder end. So here's an example of a ureter being reimplanted within the bladder. Ureterostomy, so that is where the ureter on the same side has been traumatized, and then you're basically rejoining the ureter to itself, so an anastomosis, if you like. So here's sort of an example on the side of that. Transureterostomy, so that's what we have here. An avulsed ureter or a traumatized ureter on one side that is being attached to the other. Ureteral stenting, so passing a stent through the traumatized ureter and using that to maintain patency, or a subcutaneous ureteral bypass, a sub, that's what we're seeing here, so implanted within the kidney and then implanted within the bladder, and a flushing valve in between, or again, ureteronephrectomy, which is obviously something that we could undertake at the hospital. So bladder laceration, depending on the level of trauma and how devitalized the bladder is, that might be primary repair or potentially partial cystectomy and repair required in those cases. You can remove quite a large portion of the bladder so long as the trizone remains intact, so that there is actually a little bit of wiggle room there. And finally, urethral laceration. In some cases, you can primarily repair that, or resect a small amount and anastomose it. If the tear is relatively small and not completely circumferential, so just taking up sort of part of the circumference of the urethra, then you can provide urinary diversion by placing a urinary catheter and then allowing secondary healing to occur around that urinary catheter, or as a more of a final solution, potentially a permanent tube cystotomy might be possible, but obviously there's going to have to be some major discussion with the owner as to the long-term ongoing care in these cases. So what about the rest of the neurological exam? Well, as we've already kind of touched on, lumbosacral plexus damage and sciatic nerve entrapment and those nerves associated with the bladder can be damaged within during pelvic fracture. So the image here sort of showing the where the sciatic nerve is sort of coming out from the sacral nerve or lumbosacral nerve roots. So it is important to, first of all, assess mentation because these cats can also suffer CNS damage and concussion if the trauma is due to an RTA. Looking at their gait, in some cases, obviously due to the fracture, this is going to be abnormal, but looking for knuckling and obvious nervous gait deficits is important as well. Assessing for nociception, so both withdrawal and true actual pain response. Assessing the perineal and sphincter reflex is going to give you some idea of those pudendal and pelvic nerves supplying the bladder, as we've already discussed, and motor and sensory function of the tail, again, as we've already discussed. It's worth noting in the cases of sciatic neuropathy, most cases are going to resolve given time. However, transection of the nerve can occasionally occur, and clearly if the nerve has been fully transected, then function is never going to return. But again, we quite often can't wait to be sure whether or not the sciatic nerve damage is going to resolve and return. We're going to need to manage the pelvic fractures before we get to that point. So quite often it's a case of counselling the owners that there is a small risk that nervous function may never return to the leg. However, in most cases it does, and because of the need to get on with fixing the pelvic fracture, then that's generally the route that we need to go down and then monitor carefully afterwards. So what about the orthopaedic exam? Well, specifically to the pelvis, if you want to assess for a sacroiliac luxation, then pressing ventrally on the dorsal iliac crest or the tubercocce here, if you sort of push that in a ventral direction, if there is a sacroiliac luxation, clearly you'll be able to feel that, and it is quite nice and obvious in most cases, and potentially that's going to be painful for the cat as well. There is normally a nice sort of triangle created by the tubericii, the tubercocce and the greater trochanter. If you do have hip luxation, for example, most commonly a dorsocranial luxation, so the greater trochanter is going to be moved more up here, you get a bit more of a sort of straight line effect rather than a triangle, which can help you differentiate that. Manipulating the hip, and especially if you have pain on extension of the hip, that could maybe suggest an acetabular fracture as well. But clearly the mainstay of diagnosis is going to be by way of imaging. So radiography is going to be your mainstay. CT can be useful in some cases, but in most cases, and certainly what we have access to in general practice, it's going to be radiography. So really we want to be taking an extended ventrodorsal, a frog-legged ventrodorsal, and lateral views of the pelvis. The frog-leg views can be quite helpful for assessing your acetabular fractures. So if you're not entirely sure, that's a good view to be able to take to highlight those if they're there. Due to the box-like configuration of the pelvis, it's practically impossible to actually have a single fracture. So if you're only seeing one fracture within the pelvis, there almost certainly is another somewhere. And some of the more common but more easily missed areas might be a fracture within the pelvic floor or the ischium, a minimally displaced sacroiliac luxation, or actually a fracture through the sacrum itself. It is important to carefully assess the sacrum and the sacroiliac junction, and also sort of proximal femur and things for concurrent injuries as well. If you have major pelvic fractures, there's a possibility that you might overlook those, and especially the fractures within the sacrum when it comes on to fixing what might be suspected as a sacroiliac luxation but actually has a sacral fracture component to it. That does change, number one, how we're going to manage these fractures, and number two, how successful we might be and whether or not even potentially the patient should be referred. So it is something to carefully assess and look at as a sacrum. CT, as we said, can be useful in some cases, more acetabular fractures than anything else, because it is very important before embarking on surgery to try and decide whether or not we can genuinely reconstruct the fractures of the acetabulum, or whether or not a salvage procedure is going to be more useful. So CT can be helpful in that regard. So starting to look at some specific examples of pelvic fractures now, and I'll sort of go through a few cases over the next few slides. So sacroiliac fracture luxation can potentially be managed non-surgically. You do tend to get a malunion and associated degenerative changes within the joint because it does still have an articular portion to the joint as well as a fibrocartilage portion. So potentially you're going to be looking at those degenerative changes causing prolonged pain over the long term. But certainly if the luxation is small, so less than 50% of the length of the joint is displaced. So in this example here, you can see that that's just clearly sort of 100% the length of the sacrum. But if it was only sort of 50% then or less, then potentially you could look at managing this quite successfully, conservatively. If there is major pelvic canal impairment, so we'll see an example of that a little bit later on, but if the body of the ilium is particularly medially displaced, especially more than 50% of the pelvic canal, then really you're going to want to manage that or risk future problems with obstipation, megacolon potentially, which once it gets to the point of megacolon, there's not really any going back. If there's injury to the contralateral limb or pelvis, so if you've potentially got a concurrent iliac body fracture, say on this side, then really you don't just want to repair one, you want to repair both. Otherwise you're going to be putting excessive force on one lot of implants and risking failure of that implant. So you really do want to repair both if you're going to repair any. If there is marked persistent pain sort of over a few days, and the L7 nerve roots are in this region, so if you've got a complete sacroiliac luxation and this hemipelvis is hanging off those sacral nerve roots, then that can be particularly painful. So surgery may be indicated to be able to repair this and alleviate that pain in that case. And if you're going to undertake surgery, as I've already said, really it wants to be within 7 or a maximum of 10 days. Otherwise, there's going to be some major fibrosis already occurring, and actually getting reduction of these fractures is going to be quite difficult. So this is the example from the previous slide. So here we've got a complete sacroiliac luxation with associated pelvic floor fracture, which is sort of a little bit obscured by the position of the tail here. So this was repaired by a sacroiliac lag screw that was placed through here, and you can see that's sort of quite nicely reduced the sacroiliac luxation, as well as ensuring that we maintain a nice open pelvic canal. So lag screw fixation is the preferred method of repairing sacroiliac luxations wherever possible, because you are completely reducing that fracture and the associated friction between the two bony surfaces is going to provide some additional support to the lag screw that you have placed through there. When placing the lag screw, it's important to get it 60% the length of the sacral body, so that you reduce the chances of the screw loosening and coming out, but we'll come into complications in a little bit. However, in some cases, if there is a sacral component to the fracture, then it's not necessarily always going to be possible to place a lag screw, because the landmarks that you look for on the sacral wing are essentially going to be missing because they're still attached to the medial aspect of the ilium. In which case you may look at something like this. So this is a transilial pin. So you can see in this case, this is a sort of slightly nasty fracture, but again, we've got the sacroiliac luxation fracture on this side with associated pelvic floor and ischial table fractures here. So this is a transilial pin. Ideally, the wings of the or the ilium on the fractured side would have been a little bit more medially compressed, and that would have opened up the pelvic canal a bit more, but still clearly the pelvic canal is a lot more open here than it was previously. Here you can sort of see what we were discussing about the sacral component of the fracture. So it's only relatively small, but because the fracture isn't going straight through the joint space and is actually going through the wing of the sacrum itself, it meant that when I got in there, although this wasn't particularly obvious on this x-ray here, and I wasn't sure whether or not the sacrum was fractured or not, when I got in there, it was quite obvious that the articular cartilage, which is one of your main landmarks for placing the screw, was gone because it was still attached to the medial aspect of the ilium here, which meant that the landmarks for a safe drilling of a lag screw was gone, and therefore the risks of hitting the neural canal, the sacral nerve roots, blood vessels, or the lumbosacral disc outweighed placing the benefit of placing the screw. So that's why I went for the transilial pin in this case. So this is an example of what we might do if we had a bilateral sacroiliac luxation. So again, providing that the at least on one side, that you don't have a sacral component to the fracture and that it is truly through the joint space, probably this side, so the direction the screw is placed, that you still have your landmarks visible. Then you can actually drill the full 100% of the sacral body, which to be honest is what I tend to do anyway when I'm only placing a unilateral screw, but drilling the whole length of the sacral body, and then also drilling your ilial wings on both sides, placing a lag screw through the entire length, and then on this side it's not radio opaque, so you can't see it, but you would place a nut on this side of the screw to be able to hold everything in place. This is going to be much stronger and much more preferable to placing a transilial pin in the case of a bilateral luxation. So what's the prognosis and the complications? Well, it tends to be quite good whether or not treated conservatively or surgically, to be honest, but the surgery is going to allow more rapid return to function and potentially resolution of pain if that's present. Certainly if there are contralateral injuries, then it's going to be more important to take the strain off the implants on the other side. And it's also going to decrease the risk of constipation or megacolon going forwards, because you're ensuring that you're keeping the pelvic canal diameter open. So what potential complications are there? Well, it is in cats, it is quite a small corridor that you've got to place a screw. We tend to be placing either 2 or 2.7 mil cortical screws, and there's only a 5 millimeter squared safe corridor to place that screw. So there's not much margin for error. So potential complications if you don't get the placement ideally right is you place the screw too dorsally. That's going to end up in neural canal impingement and potentially damage to the chordae equina. Having said that, it doesn't tend to occur very often, and you can tend to feel if you're going in the wrong direction when you're actually drilling. So usually you can adjust for that. To ventral placement, the median sacral vessels do lie sort of underneath and medial to the sacral wing here, so potential damage to those. Plus, if you do go out too ventrally, then the screw is not going to have enough bone stock and it is going to become loose quite easily. Cranial placement, so if you come out too cranial, you're going to go through the lumbosacral disc, so again it's going to be painful and your screw is not going to be secure. Or caudal placement coming out the back here, well, that's in the region that the sacral nerve root is exiting the neural canal, so you would risk damaging that. If your screw is too short, so we discussed about that, you want your screw length to be 60% the length of the sacral body. If it's too short, then you risk the screw loosening and failing too soon. And there is also potential for you to entrap the L7 nerve root when you actually screw the lag screw tight, so that you pull the ilium into the sacral wing. If that does occur, it's very obvious post-operatively because the cat's going to wake up in extreme pain, but it's relatively easily fixed because you just knock the cat out again, take it back to surgery, undo your lag screw, poke all your soft tissues, sort of get a curved blunt hemostat behind there, make sure that you've got everything out of the way and retighten it, so that's relatively easily fixed. Okay, so moving on to fractures of the ilium now. So again, surgical versus non-surgical management. In the vast majority of cases, ilial body fractures should really be managed surgically because conservative management will lead to malunion, and that can frequently narrow the pelvic canal, leading to that obstipation and sort of dystocia issues. And there is sort of a contrast study showing a pelvic fracture that has led to that here, and this is obviously megacolon here. If we do get to this stage, there is very little that can be done to be able to treat this. Surgery again is going to allow more rapid return to function and ambulation and resolution of pain. And if you are going to go down the conservative management route, then really you want to take x-rays 7 to 10 days later to ensure that no further displacement has occurred. Because if, say, the fracture was very minimally displaced initially, so you decided to undertake conservative management for whatever reason, you really want to make sure at 7 to 10 days, so before that window closes for potential surgical management, that you haven't ended up with sort of further displacement and narrowing of the pelvic canal, so that you can address that if required. So surgery to do with the ilium is essentially aimed at addressing the weight-bearing axis, so the body of the ilium. So that is caudal to the sacroiliac joint and cranial to the ischium, really. So when these fractures occur, usually the caudal fragment is displaced medially and cranially, and we'll see an image of that in just a second. There is a risk slightly greater risk than sacroiliac luxation to the sciatic nerve in these cases, because the caudal bone fragment can potentially be quite sharp. So as it pushes medially and cranially, very, very occasionally it can lacerate that sciatic nerve. So it's just something to be aware of. And also when you're manipulating these fractures to get the fragments back into position, again, there is a risk of trauma to the sciatic nerve. Most of the fractures tend to be oblique in a cranioventral to caudodorsal direction. Occasionally you can get transversal comminuted fractures as well. And again, these are going to be occurring in combination with either pelvic floor, ischial, or sacroiliac fractures. So here's an example of a fractured ilial body. We've got that oblique orientation that we were discussing, so you can see that here. And this is an example of a ventrolateral plating. So I'll show you sort of an image with a lateral view in just a second, but essentially you are placing the plate as ventrally on the lateral aspect of the pelvis as possible, because that's where you have the greatest cortical bone stock. Unfortunately, within the ilium, the more cranial you go, the less cortical bone there is, and the more trabecular bone there is. So not only are your screws not very long, they're not in particularly strong bone either, which does run the risk of implant failure. So if you place the implants as ventrally as possible, a cortical bone is ever so slightly thicker, so you're going to get slightly better screw purchase in those cases. Okay, so you can see a lateral view. In this case, this is actually a Synthes locking compression plate. So these screw holes here, one of them will be to take a threaded locking head screw, and the other will take your traditional cortical screw to allow some compression or some angulation if required. So you can see here, the more cranial they are, the more they try to apply the plate to the ventral aspect to get the greatest amount of bone stock. And also because the fracture is sort of extending quite close to the acetabulum here, to be able to get the bone stock to place the screws caudally, they've brought the plate over the dorsal aspect of the acetabulum here. To be able to get that approach, what's going on here is as well as your sort of typical ventrolateral approach to the wing of the ilium, which you would make sort of lying along here and then do a gluteal roll up to get access to the wing of the ilium. They've also done a trochanteric osteotomy, so osteotomize the greater trochanter to be able to get access to the dorsal aspect of the acetabulum, and then that's been repaired by pin and tension band wires, so making the approach slightly more tricky in this case. Worth noting actually that locking implants can be quite handy in these cases, because of that limited cortical bone stock that we were talking about. The locking implants take away the required friction between the plate and screws, making it slightly more secure. So contouring is very difficult to the wing of the ilium, so locking implants make the contouring a little bit less important. It doesn't have to be quite as spot on as it would otherwise have to be, and also the locking ability of the screws provides some of that axial stability, given the fact that the cortical bone is quite thin. So something that I tend to use in cats with ilial body fractures is the string of pearls plate, because that can be contoured quite nicely, and the screws do provide that locking function. So this is just an example of dorsal plating of an ilial fracture. There was a study a few years ago that suggested this to get around the lack of cortical bone stock within the ilium. It does mean that you can place obviously longer screws, so you've got potentially better screw purchase. However, the downsides to it is you do end up with more soft tissue trauma to be able to get this plate placed dorsally, and equally it can be quite difficult to, you've got a relatively thin and sharp border to the ilium here, so your screws need to be passing directly down the center of the wing of the ilium, and actually getting that screw placement can be a little bit difficult as well. So because of both of those reasons, I would certainly go for the ventrolateral plating, and if required, if you need that extra stability, actually double plating, one above the other, the lateral aspect. So prognosis and complications, well, generally good, but these animals do need to be strictly rested for 4 weeks afterwards because, as we said, you have your implants haven't got the same bone purchase and strength as they would in, say, a long bone fracture. Complications that you can see: screw loosening, especially, as we said, if you aren't managing contralateral injuries. And if you do end up with that screw loosening, then you could end up with pelvic canal narrowing, which is obviously what we're trying to avoid. Screw breakage, especially with the string of pearls as opposed to your traditional locking plates, because you're using standard cortical screws instead of locking screws in the string of pearl plates, then the cortical screw's diameter isn't quite as large as a locking screw is, so your screw plate interface is potentially a point of weakness. But to be honest, even with the locking screws, occasionally screw breakage, or with your standard DCP plates, you can still get screw breakage. Laceration of the sciatic nerve due to the sharp bone fragments that we discussed, and potentially hemorrhage as well. The iliolumbar vessels run on the sort of ventromedial aspect of the wing of the ilium, so occasionally, due to the sharp bone fragments and manipulating as you are getting things back into position, you can cause hemorrhage that way. Okay, so moving on to the hip luxation now. So as we said before, it's usually in a craniodorsal direction, as is illustrated here, and you get that straight line instead of the triangle that we discussed earlier. If the hip's luxated, then the teres ligament is going to be torn along with the joint capsule. The teres ligament usually tears sort of mid-body, but it can also occasionally avulse its attachment either to the femoral head or the acetabulum. Additional trauma is also possible to the gluteals or the acetabulum margin, or the femoral head articular cartilage, especially if it's been sort of rubbing around the acetabulum for a few days. And as these animals are walking, in most cases it's going to be non-weight bearing lame, but if they are bearing any weight, then the limb is going to be adducted and externally rotated. So management, you can absolutely try closed management. This is going to be done by anesthetizing the animal, externally rotating the limb, applying some cordodistal traction, and then internally rotating the rim to try and replace that femoral head within the acetabulum. And then after you've done that, flexing and extending the hip to try and disperse any hematoma that might have been within there. Contraindications to this to be aware of is if you've got bilateral injuries, so bilateral luxations, which just tend to be quite rare but can occasionally happen, or more commonly if you've got concurrent fractures to the pelvis or the contralateral limb or the luxated limb, then clearly you don't want to be sort of pulling around as much as is necessary to close reduce a hip. If you've got contralateral injuries that are going to require an early return to weight bearing on the luxated limb, so if you've got something that you want to potentially manage conservatively on the contralateral hemipelvis, then you are going to need to have a hip that is capable of weight bearing as early as possible, and if that one's luxated, then you need to try and get it in and as stable as possible, as quickly as possible. If you've tried close reducing and you end up with recurrent luxations, then clearly there's not much point in continuing to try and close reduce it. And if the animal has hip dysplasia, then you're very unlikely to be successful. There is a very wide reported reluxation rate, anywhere from 15 to 70%. So if it's possible, it's probably worth a go in the first instance. But if you are continuing to end up with a hip that's reluxating, then probably surgery is the way to go. Or clearly, if you have any of the contraindications listed as well. Just a note on EAM slings. These are a little bit controversial. They can potentially be useful in the management of hip luxations, but the incidence of sort of soft tissue complications, swelling, dermatitis, or even ulceration and tissue necrosis can be very high in these cases. And there's actually very little evidence to suggest that they actually prevent the hip from reluxating particularly. So I don't like to use them. I think if the hip's not going to stay in place by itself, this bandage isn't particularly necessarily going to help it. It might just increase the risks of complications. And I know some people that do choose to use them and have had success in using them. So I think it's just something to, if we're going to use them, we need to be aware of this, and we need to be making the owner aware as well. So what are our more open reduction techniques or potentially augmentation of closed reduction? So I've just kind of put it in here for completeness, but absolutely this is not to be recommended. This is a DeVita pin here. So after close reducing the hip, you drive a small Steinman pin from caudally in a cranial direction, sort of over the dorsal aspect of the hip here. You've got very little landmarks other than the sort of greater trochanter in the pelvis in which to guide you, and clearly the risk of skewering the sciatic nerve as the pin passes through here is very great. I mean, it's pure luck whether or not you hit it or miss it. So this really shouldn't be recommended. Remember that the sciatic nerve is going to be running down the medial aspect of the wing of the ilium here before it's going to come out laterally and sort of coursing dorsocaudally to the hip round here before going down the caudal aspect of the hind limb. So clearly placing a pin directly where the sciatic nerve is coursing sort of caudodorsally and laterally at this point is really asking for trouble. The other option might be placing a flexible ESF. So you basically place a pin in a ventral-dorsal direction, dorsal-ventral direction through the ilium here. Place essentially what is an IM pin down the femur, and then have a right-angled frame with a rotating arm to be able to fix that in place. Doesn't seem to be used particularly frequently, to be honest. I couldn't find any pictures of that. So your open reduction techniques, three essential techniques that all have their pros and cons. So this is a hip toggle here. So the femur is drilled from where the teres ligament attaches through the to the point of the third trochanter, essentially. You do need an aiming device really to be able to place this bone tunnel, or otherwise you're going to have to end up with quite a lot of soft tissue dissection and trauma to be able to exteriorize the femoral head enough that you can actually drill from the point of the teres ligament attachment. So that's something that makes it a little bit more tricky. And then you place you place a bone tunnel through the acetabulum from the other attachment of the teres ligament. Place your toggle through there, place your suture through, and then tie this over a button at this point here. So placing the hip toggle does lead to quite a good stability and range of motion post-operatively, but clearly this toggle and suture can fail earlier than you would like it to, and then you've got a sort of slightly more tricky revision surgery on your hands, and sort of a toggle floating around somewhere in this region, sort of within the pelvis as well. Transarticular pinning, so that's what we've got here. This is a very strong way of repairing these luxations, but you're going to have a second surgery to go in and remove that pin after 2 to 3 weeks. Otherwise, because eventually that pin is going to fail, because the pin is not going to allow a normal range of motion within the hip, because it is a ball and socket joint, and essentially you're only getting a swinging hinge joint with the pin, so it is going to fail at some point. And if you haven't removed it before it fails, then it's going to snap at this point here. You've got a sharp pin that's going to start wanting then to migrate, probably in a medial direction, or even potentially in a lateral direction. It's going to be very difficult to grab and get hold of, and also any sharp bits here, what it's going to do is it's going to nicely macerate and remove all of your articular cartilage off the femoral head here. So can be useful potentially as a secondary measure if a hip toggle or iliofemoral suture has failed, then it may be something that you require, but probably wouldn't be my first choice in managing these. I would tend to go for an iliofemoral suture, which is what we're going to discuss next. This has success rates of up to 95%, but it can be unsuitable potentially in some very large breed dogs because it is a little bit less strong. But then equally, the signalement of hip luxations not due to hip dysplasia, it tends to be cats and smaller dogs. So actually the iliofemoral suture is absolutely indicated and would work well in those cases. Your large breed dogs, if they've got hip luxation, are more often going to either have associated hip dysplasia, or the hip is going to be luxating because of hip dysplasia. So actually none of these options are particularly going to be indicated in those cases. So the iliofemoral suture, that's a suture with either leader line, fibre wire, or in cats, actually a large gauge PDS can be quite useful. You drill a hole through the origin of the rectus femoris on this sort of knobble, just cranial to the acetabulum here, in a sort of dorsolateral to ventromedial direction. You then drill a hole through the proximal femur, just distal to the greater trochanter. You place figure of 8, in this case leader line, that has then been crimped tight. Postoperatively, the limb is held in a slightly abducted and internally rotated position, and then over a period of several weeks, as that suture or lead line, etc., starts to stretch and then fail, the limb is going to return to a normal position. But by this point, the joint capsule that you're going to have repaired, and also the secondary fibrosis that's going to go on around this, is going to stabilize the hip by that time. So the prognosis, well, failure rates following open reduction and stabilization are anything from 0 to 30%. So we do need to be warning owners that even sort of surgically addressing these, there is potential that they could still reluxate. A note on sort of the hip dysplasia that we were talking about. If there's very mild hip dysplasia present, then luxations are probably going to respond quite well to treatment. However, if you've got more severe hip dysplasia, then actually these methods are probably not going to work. You're going to be much higher failure rates, so we potentially need to be suggesting salvage procedures. So in this case, as a cat that's had a total hip replacement, total hip replacements nowadays can return up to 95% of normal function, so actually better than a femoral head and neck excision. So if the animal is insured and this is possible, then then it is potentially the next best thing. So when would conservative treatment be appropriate? Well, as we've already kind of discussed a little bit, fractures of anywhere on the non-weight-bearing axis. So this diagram here shows the weight-bearing axis. So anywhere outside of this, the ilial wing or crest here, the tuberosity, the ischial table, pelvic floor fractures, etc., are going to be managed conservatively. To be honest, pelvic floor fractures, even though they can sometimes be painful, and the adductor muscles do attach here, so you can end up, if this is fractured with an animal that's got of splaying its legs purely due to the muscular attachments and the discomfort associated with it. As we've already said, the ilium has very little cortical bone stock. The pubic floor has even less. I mean, these bones, especially in small dogs and cats, if you held them up to a light, you can basically see through them. So trying to place implants on that, even 1.5 mil implants, is practically impossible or very, very difficult. So something that's very rarely done. If you've got a minimally displaced, non-painful sacroiliac luxation, as we've already said, you could absolutely manage that conservatively. If you've got comminuted non-reconstructable acetabular fractures, then there's no point trying to rebuild something that you can't rebuild. So sometimes you can manage those conservatively, but the outcome is probably going to be suboptimal. There's going to be a lot of degenerative change and potential for ongoing chronic lameness. So if possible, salvage procedures may be better in those cases. And then we're going to need to exercise restrict these conservatively managed cases for a good 4 to 8 weeks, dependent on the age of the animal and how quickly it's going to heal and all the factors associated with that, followed by house rest and then a slow return to exercise. So how about when we might want to refer to a specialist? Well, I think if we've got sort of complex polytrauma, multiple pelvic fractures, that's clearly going to make it more difficult to repair, so it might be better in the hands of a specialist. I certainly would be happy to tackle sacroiliac luxations, ilial body fractures and hip luxations at the vet hospital, depending on sort of the individual presentations of that case. But if there's sort of really complex polytrauma, then potentially that's better handled by a specialist. Sacroiliac luxation with a large sacral component. So you can see in this image here, a very large sacral, practically the entire sacral wing is fractured off here. Clearly your landmarks for placing a screw are going to be completely gone. So again, this may be better handled by a specialist to get a lag screw in here, especially if there are other fractures, or alternatively, we could potentially place that transilial bolt, as we've already discussed. Comminuted ilial body fractures might be better dealt with by a specialist, just because they're going to have access to a much larger selection of more robust locking implants that are potentially going to be better for spanning comminuted fractures. Acetabular fractures, as you can see here, with any acetabular fracture, it's an articular fracture, so it needs accurate anatomical reduction and rigid fixation, and the approach to these is quite difficult. It does include that trochanteric osteotomy that I've already talked about. It's very challenging to reduce these fractures, and it's quite difficult to place the implants, and there is also a relatively high, comparatively, rate of failure as well. So for all these reasons, probably better dealt with by a specialist. Or if you're going to go down the route of total hip replacement as a salvage, then clearly that's a referral procedure. So how about the standard post-operative care for all of these cases? It's very similar for all of them, really. Perioperative antibiotics we would provide, but there's really no indication for antibiotics after this point. There's so much musculature and excellent blood supply around the pelvis that infection is hardly ever seen, unless you've obviously got open contaminated wounds. That would potentially change the outlook. Providing multimodal analgesia, so combination of opiates, especially in the initial hospitalized period, but then potentially discharging with non-steroidals, gabapentin, paracetamol, obviously not in cats, just in dogs, but combinations of those for 2 to 3 weeks post-operatively. Strict cage rest for the surgically fixed cases for at least 4 weeks, and then house rest and then slow return to exercise. It's quite important to monitor toileting, because posturing can be painful, especially in the short term with these cases, especially with your small dogs. Providing sling support can be helpful for them, less practical in cats probably. Fecal sustenance, so lactulose, etc., just helping make it a bit easier for them to pass stool, and urinary catheterization, again, especially in the initial phase, but also in some cases needing to look for longer term management up to a month later. So it's always better to sort of deal with this sooner rather than leaving it and allowing the overstretching of the tight junctions to occur. And then rehabilitation and hydrotherapy. There is no evidence within the vet literature at all to say that physiotherapy, hydrotherapy, etc., actually has any effect. But that's not to say that it doesn't. It might still be a benefit. So theoretically, it's certainly going to reduce disuse muscle atrophy, and it might sort of help with range of motion things later on. So that's something that could be looked at. And then ideally, you want follow-up radiographs 4 to 6 weeks later, prior to return of normal exercise. So, thank you very much for listening. I hope that that's been useful and given you a bit of an overview. If you do have any questions and you want to contact me directly, my email address is at the beginning of the presentation. Otherwise, thank you very much for listening.